Να συνεχίσουμε με τον επόμενο μιλητή. Λοιπόν, για τον επόμενο καλεσμένο μας ομιλητή, για τον καθηγητή Bodaghi, ο οποίος είναι καθηγητής οφθαλμολογίας στο Πανεπιστήμιο της Σορβόνης στο Παρίσι, δεν ξέρω τι να σας πρωτοπαρουσιάσω. Είναι επίσης ο πρόεδρος του International Ocular Inflammation Society. Από το 2000 υπεύθυνος ερευνητικής ομάδας για την οφθαλμική ανοσολογία, το 2011 υπεύθυνος για το επιστημονικό πρόγραμμα International Ocular Inflammation Society, το 2012 συντονιστής του τμήματος View Maintain και ιδιαίτερη τιμή για εμάς για να μας μιλήσει ο καθηγητής Bodaghi για την παιδιατρική ραγοειδίτιδα. Alors, professeur Bodaghi, bonjour de la 11e conférence sur l'inflammation et l'infection oculaire. C'est un honneur spécial pour nous, alors je vous en prie. Μας ακούει?
Dear friends and colleagues of the Hellenic Society, I would like to thank the President, Professor Raghoiditida Moskos, for her kind invitation, and of course the Executive Board. It's a pleasure to be with you, even though it's virtual. I regret it, and I hope that in the future we will be able to gather again. Thank you for this topic, which is on pediatric uveitis. These are my disclosures. I would like to start by reminding you the importance of the problem. 10% of all uveitis cases, underlying causes and etiologies that are unique to children, with potential severe consequences as a result of delayed diagnosis, the important comorbidity of amblyopia, ocular complications that you know, and severity of vision loss tend to be greater in children than in adults. And we need the less complicated situation when we start to manage these cases. This is just the epidemiological distribution of anatomic types of pediatric uveitis. Just to remind you that whatever the country, it seems that in the pediatric population, the anterior segment involvement is much more frequent than the other segments, even though intermediate uveitis is also more frequent in children than in adults. First, I would like to exclude all the differential diagnoses and the masquerade syndromes, as they are usually poorly, if not at all, responsive to corticosteroids. We have to be suspicious when the inflammation is mainly unilateral and occurs in very young children, with the main entities reminded here: retinoblastoma, juvenile xanthogranuloma, acute leukemia, von Recklinghausen disease, Coates disease, metastatic tumors, and foreign body or vicious hemorrhage. These are slides from Professor Fuklo Wang showing you the hypopion and also the anterior segment involvement in a case of retinoblastoma, the diffuse infiltrative retinoblastoma, which shows you that we have to be careful, and especially not to perform an anterior chamber tap in these cases and look at the posterior segment. I would now start with the most frequent entity we see in children, and this is anterior uveitis associated with juvenile idiopathic arthritis. These are a few examples of what we see, and what's important is that the eye is mainly quiet. You have a smoldering inflammation going on with band keratopathy and especially posterior synechiae when you are not making the diagnosis early. The risk factor for uveitis in patients with JIA are presented here. You see in blue the JIA patients without uveitis, and in orange those with uveitis. And you see that regarding subgroups, of course, it's important to see that the female sex is important more in young girls, and ANA positivity is also important in order to differentiate these groups. Of course, uveitis occurs more often in the oligoarthritis group of the disease. This is the frequency of uveitis complications in the pediatric patients. In a study presented by our Dutch colleagues, Joke de Boer and colleagues, and you see that cataract was at that time, at least the big early millennium, the most frequent, followed by optic disc edema, glaucoma, and cystic macular edema. Fortunately, we can say, and I will show you that the incidence of cataract has significantly decreased, and this is really something important we achieved thanks to the less use of corticosteroids and more biologic agents to control the disease. Another tool which is to me very important when we take care of kids with anterior uveitis is laser flare photometry. There are publications in the literature showing that the results of this quantitative method, non-invasive method, support continued investigation of LFP as a method for monitoring pediatric UVI patients early in the uveitis disease course, even showing that you can predict the occurrence of complications and severe cases based on the evolution of laser flare values under therapy. The other tool we have used in 2008, and this was one of the first papers, I think it was the first paper, dealing with complications at the posterior segment, and this was on macular edema. It was a study in OCT in this population, all referred patients for the management of JIA in our center. They had OCT, 3 measurements, and the foveal thickness and central foveal thickness were studied, and you see here for the first time we show that we had macular alterations in more than 80% of the kids at that time. It was before the use of biologics, and it was interesting because in that time when we had visual loss, people thought that it was due to the lens, and children had cataract extraction. And in some of the cases, of course, visual loss was due to these macular alterations, and the intensive anti-inflammatory therapy and biologic agents, use of biologic agents, was able to control and to gain visual function without losing the lens and performing cataract surgery with all the complications that we know, especially when we implant those kids. Regarding treatment, you know that many options are available today. We start with topical corticosteroids, and then we go directly to immunosuppressive agents and biologic agents. I don't like the use of intravitreal corticosteroids in kids, even though it has been proposed by some colleagues. But I think that this is really very early, and we may come up with very important damage and complications. So then after topical corticosteroids, I don't even use oral corticosteroids except in cases where surgery is needed in some of these cases, and I go directly to methotrexate. And if methotrexate is not working, then I switch to a biologic agent, and it may be adalimumab or infliximab, at least at the beginning. And these are the 2 studies performed in Europe, one Sycamore in the UK and Adjuvate in France, and both double-blind randomized placebo-controlled trials in JIA-associated uveitis, and they were used, especially Sycamore, in order to have the approval of adalimumab in this indication. And there are some recent papers discussing the cost-effectiveness of adalimumab for the treatment of uveitis associated with JIA, but I think that it's difficult to take this into consideration, as we have a very, very good effect and efficacy of the drug with very few complications and a very good tolerance in these kids. But what happens when adalimumab is not working? We have other publications in the literature. This one is showing the effect of abatacept, but we are not that happy with abatacept, and I should confess that we are not using it, so it may be a possibility in some rare cases, but then we go to other biologics, or we switch between adalimumab and infliximab. But what is really important is to find in these children, as in adults, the presence of anti-adalimumab antibodies or anti-infliximab antibodies. Even though we use methotrexate in order to avoid that, it may still occur. Then in 2021, we can say that we have less severe cases. This is for sure in evidence. Early diagnosis before complications, more efficient pharmaceutical agents, no more cataract in young children, and this is really something very important, and better monitoring, and the final visual prognosis, which is much better than before. If we go now rapidly to the other subtypes of uveitis, intermediate uveitis, and this, the etiology, of course, is unknown in more than 80% of cases. No treatment if you have a good vision in these situations, but of course you can treat the kids if you have complications such as macular edema, vascular vitreal retinal tractions, and peripheral retinal detachment. We start with systemic corticosteroids in these cases, and the first line immunosuppressors are methotrexate. The second line is azathioprine, and I'm really very, very cautious before using anti-TNF drugs because of MS and juvenile MS. We really need to exclude that before proposing, in very severe cases, anti-TNF drugs. And if we now go to posterior uveitis, the one which is really important to consider is Behçet uveitis in children, and you have to act very rapidly, aggressively, especially when you have this type of lesion. So I combine corticosteroids with anti-TNF drugs. If tuberculosis again and MS have been excluded, and this is a long-term therapy, of course, in these children. The other entity, which is not a non-granulomatous but a granulomatous entity, which may combine this type of lesions at the level of the retina and the choroid, associated with keratic precipitates, granulomatous keratic precipitates, is sarcoidosis. And you have in very young children different forms of sarcoidosis and sarcoid-like uveitis, which are important to consider, which may be very aggressive. Bilateral surface retinal detachment in kids is, of course, important to consider, and you have to exclude the Vicky edge, Vokoenage-Harada syndrome, and you have to treat them also aggressively, even though usually the response and the efficacy of treatment is good. But in many cases, you need immunosuppressors, which is not always the case in adults. This is a very special case and situation and entity in young children with bilateral exudates at the macula, at the level of the macula. You have neuroretinitis, and you have, of course, arterial aneurysms, as you may see here, with ischemia at the level of the retinal periphery. This is just what we see in Irvan syndrome, idiopathic retinitis, vasculitis, aneurysm, and neuroretinitis, with the three major criteria and minor criteria I mentioned. With the poor long-term prognosis, treatment is based on peripheral laser photocoagulation and anti-VEGF drugs, which may be injected intravitreously, and also systemic or local corticosteroids together with biologic agents, which may have an effect and efficacy. This is another entity which is important to know in children, chronic infantile neurological cutaneous articular syndrome, CINCA syndrome, where anti-IL-1 drugs are very efficient, and you may have a very good response on all these different organs and tissues, especially also at the optic disc when you treat them. To summarize, we had, and I hope that I showed you that we had a dramatic improvement of visual prognosis during the last 2 decades. This is based due to multidisciplinary collaboration, the better monitoring of children with uveitis, clinically based on laser flare photometry, OCT, and early treatment, which is a major factor for ensuring the good outcome. We don't undertreat children and don't allow smoldering inflammation. What is also important is to manage complications rapidly. I would say that the most fearing complication to me these days in this setting, especially with anterior uveitis, is glaucoma. Because for all the others, we have done a lot of progress, and the situation is much better controlled. Thank you very much for your attention, and I hope to see you soon again.
Professeur Bodaghi, bonjour de la 11e conférence sur les inflammations et les infections oculaires. C'est un honneur spécial pour nous. Merci beaucoup de votre lecture. Υπάρχουν κάποιες ερωτήσεις για τον καθηγητή Bodaghi. Professor Amroudi is going to pose some questions.
Thank you. Hello. I regret not being Thessaloniki. Bonjour, Sophia.
So I have one question because I want to, to have your expert opinion on this. The intermediate uveitis is a type of uveitis that we often see in children. And you said, and I agree also that you don't need to treat if the visual acuity is good. So how often do you follow this patient? If you have a small child with intermediate uveitis and a good vision, how often do you follow him or her? How often is for this case to go into multiple sclerosis when the child gets into adult age?
This is a difficult question, much more difficult than the first one. For the first one, I would say that I'm really very keen to tell the parents, usually the parents and always also the kids when they are a little bit older, that it's important not to treat floaters. That's, to me, this is really something I learned from Professor Loang. And I think it's very important in an era where we are proposing different treatments to all of our patients, some very sophisticated treatments such as biologic agents. I think this is really one of the entities where if you have just floaters, if the vision is good, if you have no complications, no macular edema, then it's good to just monitor. And you are asking about the rhythm of monitoring. At this time, I would say, of course, 4 to 6 months. Every 4 to 6 months to me is good, but I always ask the child and the parents to be careful on the vision and test the vision themselves. Just a few days ago, I had one of my patients who was doing well, and then he came with a vision drop of 20/60, and he was really active with a lot of vitreous haze and vitritis, and I took the decision to treat him, because if the vitritis is there and becomes dramatic, the sooner you treat and the better it is. If you wait too long, if you say, come in 6 months, then you may be in trouble. This is why I asked them if there is anything going wrong, just to call me and come back in emergency. For the second question, I don't really know, Sophia. I don't know if somebody knows this answer about how many intermediate uveitis kids with intermediate uveitis develop eventually MS when they are adult. I don't have this information. I think it's really a few of them, because most of them, when they are adult, have just their inflammation control and without MS.
Thank you. We have a full house. We're expecting you tonight to address the welcome with Professor Moschos. And
I will be there.
One more question, because we have a full house for the comprehensive ophthalmologist. When we examine a child in slit lamp, it's very difficult sometimes to assess inflammation. It's very difficult to assess cells. So what's your advice to a comprehensive ophthalmologist? Should they refer? Should they trust their own eyes? Because sometimes it's very difficult even to do, for us that we have a laser flare, even to do a laser flare.
You know, Sophia, I think you said everything. Laser flare to me is the most important in children. This is really maybe the only and the main indication I keep for kids with using laser flare photometry for kids with anterior uveitis, chronic anterior uveitis, because most of the time when the general ophthalmologist send the kid by saying he's not doing well, the flare is rising, and you do the flare, the laser flare photometry, you see that it's not that high. And also the contrary, when the ophthalmologist says everything is going well, and when you make you realize the flare, you perform the flare, you see that it's getting high. So I think this is really the piece judge, the laser flare photometry, but of course it is expensive, and until I think that now you cannot even buy a laser flare photometer because there are some problems regarding production. So to me, the most important thing is that you should not see a new posterior synechiae appearing when you are following a kid with chronic anterior uveitis. If you see even a small posterior synechiae produced, and you see that, it means that you have failed in your therapeutic approach. And you need to refer that kid very rapidly to a rheumatologist, or you have to, again, review your therapeutic approach, because it's not enough. This is really, to me, very important, even though, of course, you are evaluating the anterior chamber flare and cells, but you should not see new posterior synechiae appearing when you are correctly following and treating a kid with chronic anterior uveitis.
Second question from Professor Marilita Moschos.
Bonjour, professeur.
Bonjour, Marilita. Bonjour, Madame la Présidente.
Merci beaucoup. Moi, je n'ai pas de questions à vous poser. Je voulais juste vous dire que c'était un grand plaisir de vous avoir avec nous. Malheureusement, vous n'êtes pas ici. C'est très dommage pour nous et pour moi personnellement.
Pour moi aussi.
Je voulais vous remercier pour votre présentation. Les cas que vous avez montrés étaient très éducatifs, surtout pour les plus jeunes. Et j'espère que la prochaine fois, vous allez être avec nous et on vous voit ce soir. Merci.
On se voit ce soir. Je voulais encore m'excuser auprès de tous les amis grecs. I want to give my apologies not being with you. You see, I'm talking French because Marilita is talking so well French, and I'm ashamed that I cannot speak in Greek. This is really something fantastic. When I see so many of you speaking French, I'm really impressed. But you know that the friendship between Greece and France is very old, and I regret not being with you. I hope that this evening we can have this welcome together, because it's very important for me and for IOIS. Thank you very much.
Merci beaucoup et à plus tard. Merci.
À plus tard. Bye bye.